Thank you very much. We on to the masterclass after two very good, very interesting debates. And we have Dr. Ehab, who's going to be talking on suprachoroidal macular buckle in myopic macular holes. So look forward to your very interesting talk, Doctor.
I'd like to thank you first for the kind invitation, and it's a pleasure to be with you. And I can see a lot of my friends in this session, so I'm very happy to be so. The other thing is I'm very happy also to be sharing something common between me and Parolini, which are the buckling technique or the macular buckling technique. So let's go back first. So my talk today is about suprachoroidal macular buckling for myopic or vitreomacular interface disorders. What have we learned over the last 13 years working with this technique? First of all, let's say that we can close most holes just by doing vitrectomy, ILM, peeling, and flaps, even with these patch techniques that we spoke about. But what about failed cases or cases with extreme myopia beyond 32 millimeters axial length? The retina is under stress, and sometimes it fails to yield back in the sclera, especially while we know that myopia is an ongoing axial elongation procedure, especially when you have a staphyloma. So what about this progressive elongation? And that is the role of posterior support of the macular area. And the longer the sclera extends posteriorly, the more the tractional forces happen over the retinal surface, whether tangentially or anteroposteriorly. By supporting the sclera from the back, you actually decrease these tractional forces over the macular area. And this happens by macular buckles. This article is from the Indian Journal of Ophthalmology, and I'm happy to see that article because it reviews most of the techniques that are used or types of buckles that we use to try to counteract that or use macular buckles. I won't speak into it because I know my dear friend, Dr. Parolini, will speak about it in a couple of minutes. So when we look about the support of the sclera that happens, we know that either we can go by supporting the sclera and the choroid, which is the classic macular buckles, whether we use the endo implants or other implants, and this new implant by Ackman, which I'll tell you that I personally like this buckle over the rest of the buckles because it has a flat surface rather than a convexity. And you can achieve a similar buckle like this, and you can see this buckle here when we go one step, which is the suprachoroidal buckle technique, and you can see exactly the same indentation that happens in the macular area compared if we put a scleral macular buckle. The difference is here we use the sclera and the choroid to indent, but here we're using just the choroid to indent the choroid and support the retina. So how does this happen? The idea behind it is to bring the choroid back to the retina by using a filler instead of using the sclera. Theoretically, you don't need the sclera to achieve chorioretinal adhesion or to support the retina. You need the choroid to support the retina. So how does this happen? You theoretically bring the staphylomatous space instead of between the choroid and the retina to between the choroid and the sclera, or bypassing the problem of axial elongation that happens. For that, we developed 13 years ago this catheter that has light, and it could be connected to a filler. If you take a section in this catheter, this is how it looks like. It has a halo lumen inside and a light fiber to illuminate and shine. It is atraumatic at the tip because it has like an olive blunt tire shape here. Then you connect it to a filler that you can inject and separate the choroid or support the retina. What do we use as fillers to be injected in that space? We use Perlane, which is a cross-linked hyaluronic acid. It's normal as the Helon that we use inside the eye. And once you inject it, it stays as one bubble, and it can last in the subcutaneous tissue as fillers for up to 14 months. And is this enough? The answer is yes. If you can separate the choroid from the sclera or support it for at least 8 months, it never goes back. And that was one of the questions that we were asking ourselves, how we're going to keep that space separated for time. So it's nothing but more of a hyaluronic acid cross-linked as we use inside the eye. So the technique again involves that placing a suprachoroidal catheter in the suprachoroidal space after making a scleral incision 4 millimeters behind the limbus, and in the back part of the eye we inject the filler, separating the choroid to close the macular hole or the vitreomacular interface if it's a case of schisis. Then we developed another catheter that is non-illuminated. By time we found that we don't need an illuminated catheter. We can use this drug-delivered catheter that we developed with Med1 to inject the filler in a similar technique without the need of the light. So we make a scleral cut 4 millimeters behind the limbus, expose the choroid, then gradually open the last lamella by diathermy. Then we inject viscoelastic to separate the choroid from the sclera, and the catheter is threaded to the back part of the eye till you reach the target tissue, or right underneath the macula if it's a macular hole, or underneath, of course, the macular area if it's just foveomacular schisis, and you can support the back part of the eye. You glide the catheter by pushing on the sclera, and you can see the catheter moving in the suprachoroidal space all the way to the back part of the eye. Once we are underneath the target tissue, you start to inject, and you can see the choroid lifting as creating a scleral macular buckle, but it is theoretically a suprachoroidal macular buckle, and you can see flattening on table of the macular hole. So this is while using the non-illuminated catheter. Now, and you can see this choroidal separation that happens. The choroid is separated from the sclera and supporting the macular hole, and you have an excavation here. This is not what ideally I want to see, and I'll tell you why in a moment. I don't need that height, which is created also by scleral macular buckles. The height is a bad thing, not a good thing. You need just to reconfirm the back part of the eye. So this is over-injection, and I'll tell you in a minute how this happens. Another patient like this chronic macular hole that we moved the ILM several times, myopic, failed to close. Again, in the suprachoroidal space, you start to inject, you can easily, and in this slide, you can see the expansion of the choroid. What happens? The choroid starts to elevate. We just need a good choroidal support, not too high, to support the area of the macular hole. If you take an OCT of that similar patient, that's what you get. You get the elevation inside the eye, like it looks like a scleral buckle, and at the back, you see the excavation that happened, and the choroid goes up, supporting the retina, and the sclera at the back here with the resonance, and a big cavity created, supporting the macular area according to make it how high you want it or how wide you want it. You can control it by just moving the catheter in the suprachoroidal space to achieve the height and the width that you need. Now, in real life cases, this is a patient that had failed macular hole surgery twice, a myopic patient in a staphyloма, and you can see the fluid is trapped in there of staphyloma, and the edge is elliptical because we removed the ILM several times before, failed, and the fluid stays trapped inside. So in this patient, we got the catheter inside the eye again, all the way you can guide it according where the location is. And right underneath where the hole is, you start to inject. This is an eccentric hole at the same time, which is more challenging to put a scleral macular buckle. And once you inject, you can see the choroid now indenting, and you can see it clearly, the choroid is supporting the hole right now, and the fluid is pushed posteriorly outside the staphyloma. And this is the area that was buckled for that patient. This is how it looks like pre-op, and that's on table what you get by creating the suprachoroidal macular buckling. 1 month post, you can see the indentation is right there, and this is how it looks like with the choroidal separation and the cavity that's created, the choroidal thickness, and the hole closed over this. That is taken at 1 month. In 4 years, that same patient, again, you can see the indentation, and we ask ourselves, what is filling this space? What happened? Because if we are looking at hyaluronic acid, we expect it to go away by 12 to 14 months. But we found that if you separate or sever the choroid from the sclera or remove the septa that connects the choroid to the sclera in an area of staphyloma, the choroid tends to stick to the retina. It never goes back again. And that's why after 4 years, you still have that choroidal indentation. And we've been following up for more than 10 years. These holes never open because you bypass the pathology. And even if scleral elongation happens, it happens behind the area that was already buckled before. Now, another patient, you can see the picture with the retina opened and post. Again, the hole is closed, and the separation that happens right here, that's taken pre and post. And for that serial patient, 1 month, 12 months, and 6 years post-op, still you have the excavation, and the retina is well supported, and the hole is closed. The height is different, of course, but still the separation over 6 years, these holes are closed, and the support is still there. Several patients, this patient was done under vitrectomy, ILM peeling, a flap under silicone, and still we got silicone trapped through the macular hole. We removed the silicone and we just put a buckle in that area, and you can see that the retina is flat again with no tamponade, just by using the macular buckle and an air bubble for 2 days after. Now, I showed you this patient here again. doing a buckle, just to show you the technique. Theoretically, this patient, you can just do a vitrectomy and close it. So I'm just showing you for the sake of the technique itself, how it goes. So let's put this here. And if you see this patient, you can even remove the ILM later on once the buckle is created here. The macular hole is before injecting. Once you inject, you can see that expansion wave. You can control the height. You don't want it too high. This patient, I'm showing you the bad things that happens if you inject too much. You're actually indenting the macular hole and it might open. And at the end, we remove the ILM in this patient. It's easier, of course, when it's supported. There you can see sometimes you can manipulate the edges by pulling centrally instead of centripetally to close such a hole. So this is the dome, how it looks like. I don't want it to look like this. What have we learned by time? Theoretically, you just need to restore the normal convexity of the back part of the eye. If you do too much indentation, you might affect the circulation inside the choroid. And this is what sometimes happens even with scleral macular buckles, and it's always a point of debate. The initial data was published years ago in 2014 for the first series. We always ask two questions. What about the choroidal perfusion? Because it's a debatable point. I spoke several times with Carlos Mateo about the perfusion that happens and the alteration that happens in the retinal pigment epithelium when we put scleral macular buckles. So let's look here. This patient, the trial we did in Japan, is looking into the choroidal perfusion with ICG after doing macular buckles. For a 21-day after, you do get a little bit of macular affection here for the choroidal perfusion. Is this the same with scleral macular buckles? The answer is yes. But is this dangerous? No, because the perfusion, if it is a concern, the amount of indentation is very important. If you put a too high buckle, then you're pressing on the perfusion, whether you're using a metal scleral buckle or a suprachoroidal buckle also. So this is a point to know in mind. You're trying to restore the normal convexity, not too much indent. The second point is the choroidal thickness. A very thin choroid definitely will have some affection of the perfusion. The higher blood supply is something in our favor because there's lots of posterior ciliary vessels that feed the macular area. So that helps us in making it more comfortable by putting a buckle back there because we know we have high perfusion in the macular area. The resorption cushion effect is something reversible because this is not a metal compression over the circulation, but it is a cushion of viscoelastic, which is in favor of this technique. And let's look at this patient here after creating a macular buckle. What is the normal progression of myopic changes like in this patient? This is the area that was buckled. Taken at 6 months, you can see that there, of course, there are also some myopic macular degeneration outside the back of the buccal area. At 12 months, you can see that also there is progression outside. This is a site that patient had a CNV. Look at the progression of the myopia changes even outside the buccal area. So to see myopic chorioretinal adhesion while you do macular buckling, it is present, not just to the sake of perfusion, but these are normal changes that happen over years. If you look at this patient 3 years compared to 1 month, though there's some changes, but it's outside the area that was buckled. It can happen inside and outside as well. So that is what point that we always argue upon when I see Carlos about the choroidal perfusion. There is definitely a learning curve. To put a catheter inside the eye, you should think about hemorrhage. So there are tricks how to avoid hemorrhages. Some of what we call track hemorrhage, while pushing the catheter through the suprachoroidal space, you might have some hemorrhages around, and there are ways to get around that. I'll speak about it in a minute. What have we learned by time? We're using a suprachoroidal macular catheter. You can achieve any type of buckling for different forms of staphylomas because you can guide the catheter even in type 5 staphylomas where the staphylomas is eccentric. You can always reach that by the catheter. So this is one thing that you don't always have to stick to scleral macular buckles to place it in one side, but you can achieve buckling over several areas by guiding the catheter to whatever area you want. How to avoid hemorrhage? It goes step by step. I like to use first between 11 and 1 o'clock if I'm using superiorly, or start at 5 to 7 if I'm using an inferior location to entry. When you open the last lamella, always open by diathermy, which avoids cutting the choroid and at the same time avoid damaging the choroid. You need an intact choroid to do this technique. While pushing the catheter inside, always push against the sclera. Don't push against the choroid. So you push against the sclera and let the sclera glide the catheter to the back part of the eye to the target tissue. And at the same time, the catheter at the tip is an olive tip, so it's actually dissecting. It's not cutting its way through. Use sometimes when you have resistance, inject a little bit of viscoelastic on your way, which actually separates the choroid from the sclera and makes it gliding easier. Create a dome and never expand the dome to make it high. You need to restore or bypass the staphylomas. Don't over-indent. Whether you're putting a scleral macular buckling or using a suprachoroidal macular buckling.
Doctor,
We learned
1 minute left.
I'm sorry? How to control hemorrhage, as I told you about it, and at the same time keep the pressure high. Sometimes when you have a little bit of hemorrhage, you can increase the intraocular pressure, and this technique is done just by a chandelier. You don't need to do it while doing a vitrectomy. So most of these patients, you can do it in a 20-30 minute procedure by just putting a chandelier and sliding the catheter to the back part of the eye. It's not for extreme choroidal thickening patients. If you have a patient less than 80 microns, then I would go for a scleral macular buckling, not a suprachoroidal, because you don't have choroid to indent. So this is one of the mires that we find my time. In super thin choroid, you always go for scleral, not suprachoroidal buckles. Elevating the choroid usually to the level of the optic nerve, which is the 0 point, is very important to restore the normal convexity. You don't need to over indent, as I mentioned. Learning curve is very important, and at the same time, this solves the problem of axial elongation, which is a continuous process in high myopic eyes. We have to always think about myopic detachments. It's an ongoing process, and you will have later on elongation of the eye. So posterior indentation, whether scleral or suprachoroidal, is the way to go. These results encourage us to use it even in failed patients in which the initial procedure didn't work, or sometimes in very high myopic holes with staphylomas. I always use this technique. Thank you so much for your attention.
Thank you very much, doctor. That was an amazingly skilled surgery. On to you, Ashay.
Sir, extremely mesmerizing talk, and I didn't know the talk or the surgeries were more beautiful. I couldn't decide. But anyways, I just want to ask, is there axial length, certain axial length which guides you to this technique, or is there any prerequisites for doing this technique, or is it primary text?
See, when you see the patient preoperatively and you see that there is a deep staphyloma inside, I know with the evolving techniques, a lot of surgeons can solve a lot of things by putting, for example, multi-layer flaps or whatever. But when there is a deep staphyloma, then I think about using this technique in supporting the retina. As Dr. Parlini just mentioned, you can use this technique or macular buckles in association with retinal hydration to increase the retinal elasticity. So now when this technique is a little bit, at least in my hands, takes like 20-30 minutes, I always use a support, even if I'm using it in association with something else. And I think just by supporting the retina to close the hole on table, you get dryness of the fluid, whatever it is, even in a staphyloma. So as I showed you, one of the patients here that was resistant for vitrectomy before ILM peeled, and still you have an elliptic irregular hole on table. When you inject just to close the edges of the hole, it dries up by quite some time. And this is done, as I just mentioned, underneath just a chandelier light or whatever. So before, I was using it not as an initial procedure, but using failed myopic macular holes, like those that you use, whether use eye lamp flaps or whatever. If it failed, then I go ahead with that. But now, in certain indications, like more than 34 millimeters, you know that the risk of failure is higher. Then I always put a suprachoroidal macular support.
Sir, just last question. I know we have a short of time, but you completely peeled off the ILM. Do you think?
No. ILM, that was one of the patients I was showing just for the sake of the technique, but I never remove an ILM in these patients. If it's just a myopic macular hole or a axial lens, you just support the retina from the back, like putting a regular scleral macular buckle. It closes. You don't need to remove the ILM. So you can do it in association with another technique, or just closing the hole posteriorly.
Thank you. Thank you very much, doctor.